Dear teachers and classmates, hello, I am PGY Dr. Lee, and today I will present an EBM discussion. My mentor is Dr. Liu. The following content will be presented according to the 6 As of EBM: analysis, asking, acquire, appraisal, apply, and audit. First, the analysis section. The case for this report is a 65-year-old female diabetic patient who uses SGLT2 inhibitor medication to control blood sugar, maintaining AC sugar levels between 130 to 180 mg/dl. Additionally, the patient has osteoporosis and a history of multiple fractures. The most recent significant fracture was a T12 compression fracture, treated with vertebroplasty at our hospital's orthopedics department. However, since August last year, she has been bedridden. 2 weeks ago, during an attempt to get up, she fell, resulting in a right forearm fracture. During this visit, the patient complained of perineal and urinary tract itching, suspected to be a UTI, possibly related to the use of an SGLT2 inhibitor. After evaluation, her medication was adjusted to increase the metformin dose, and perineal hygiene education was provided. However, due to her bedridden state, the expected effect may be limited. Based on this visit, we are exploring whether there are other methods to prevent UTIs in diabetic patients using SGLT2 inhibitors. Through literature review, we know that UTIs are a very common complication of SGLT2 inhibitor use, with females and diabetic patients being at higher risk. Postmenopausal women, due to decreased estrogen levels and changes in the urogenital microbiome, are more prone to UTIs. Regarding UTI prevention methods, previous studies have shown that cranberry consumption is a proven effective method for preventing UTIs. The PAC compounds in cranberries have anti-adhesion effects against E. coli and Candida albicans. Wet lab results also show that cranberry juice has antibacterial effects against common UTI pathogens. Studies have also confirmed that cranberry juice helps maintain healthy vaginal microbiota in postmenopausal women and can reduce UTI occurrence in elderly patients, thereby reducing the need for antibiotics. After analyzing the clinical scenario and reviewing the literature, we move to the asking phase. Based on this clinical case and prior cranberry research, we aim to explore: can cranberry supplements effectively prevent UTI recurrence in diabetic women using SGLT2 inhibitors? Our PICO is as follows. P. Patient. DM female under SGLT2 inhibitor for blood sugar control. I. Intervention. Cranberry supplement intake. C. Comparison. Placebo. O. Outcome. UTI episode. The type of study is preventive, as antibiotics remain the primary treatment if a UTI occurs. 3. Acquire. The keywords used are as above, and we searched studies from the past 5 years using Boolean logic. The selected articles were limited to RCT level or above. Article selection priority was based on the EBM pyramid, from top to bottom. The first database searched was the Cochrane Library, yielding 2 articles. The second database was PubMed, yielding 5 articles. In total, there were 2 plus 5 articles, with no duplicates. 5 articles were excluded for not matching the PICO, and 1 was excluded for being below RCT evidence level, leaving 1 article. This is a 2024 RCT article, likely from Italy, published in the Nutrients Journal with an impact factor of 5.0. The study design recruited postmenopausal women with DM, using SGLT2 inhibitors, and with a history of UTI. They were divided into a cranberry group and a non-cranberry, placebo, group, and UTI recurrence rates were tracked over 6 months to assess differences. Appraisal. Patient. Female with DM. Intervention. Daily oral highly standardized cranberry extract Phytosome, 120 mg. Comparison. Placebo. Outcome. UTI prevention. At least 1 previous UTI within 1 year. Clear. Specific question? Yes. This was a randomized 1:1, double-blind, placebo-controlled, parallel group, 6-month clinical supplementation study. The study was conducted at the Metabolic Division of Santa Margherita Hospital, Azienda di Servizi alla Persona, Pavia, Italy. Allocation to the supplementation groups was performed via a computer-generated random blocks randomization list, and random assignments were concealed in sealed envelopes. 2. Were subjects randomly assigned to different groups? Yes. 3. Were all subjects who entered the trial accounted for in the study conclusions? Initially, 53 subjects were screened and 46 recruited. During the randomization, 7 subjects were dismissed because of lack of informed consent. Finally, 23 subjects were allocated in each group, and none was lost to follow-up. And 4. Were subjects, healthcare staff, and researchers blinded? This was randomized, 1:1, double-blind, placebo-controlled, parallel group. Allocation to the supplementation groups was performed via a computer-generated random blocks randomization list, and random assignments were concealed in sealed envelopes. Yes. 5. Were the baseline characteristics of the study groups similar upon entering the trial? Yes. 6. Apart from the experimental intervention, were Thoyo run treated the same? Yes. All subjects consumed 1 capsule per day. Placebo and active were indistinguishable, colorless, tasteless capsules packaged and administered in an identical manner. Placebo and active capsules had the same composition except for the active substances, PACs. Polyphenol consumption, including vegetables and fruits rich in polyphenol, was limited during the trial and at least 72H before study. 7. Were the intervention effects fully reported? Yes. Repeated measures analysis was performed to assess the interaction between time, presence of infection, and treatment. Regarding the UTI episodes in the intervention and placebo group, Figure 2, interaction between times for treatment was statistically significant, p equals 0.001. 8. Was the precision of the intervention/treatment reported? Yes. Considering UTI episodes during the 6-month supplementation period, an increase of 1.321, 95% CI, minus 0.322, 2.9650 was observed in the placebo group, while it remained at a steady value of 0.393, 95% CI, minus 4.230, 5.016 in the supplemented group. In particular, at follow-up 4M, 9% of the placebo group showed infection versus only 3% with cranberry supplementation. 9. Were the benefits of the intervention worth the harms and costs? No adverse event or safety concerns were reported in either group. Glycemia and glycated hemoglobin values, secondary outcomes, were not modified at the end of 6 months with respect to the basal values in both groups, as expected. While in terms of quality of life, per the SF-12 health questionnaire, there were no differences between the two groups. An improvement in SF-12 quality of life was observed in both groups, 6 months versus basal. Yes. 10. Can the study results be applied to your context? Patient, DM, female, menopause, SGLT2 inhibitor, suspect UTI at home. Highly standardized cranberry extract Phytosome supplementation reduced UTI recurrence. Yes. 11. Is the intervention more valuable to the patient than any existing interventions? No evidence yet reported the effect of antibiotic to prevent SGLT2 inhibitor-related UTIs. Can't tell. 5. Apply. Shared decision making plus 4E model. Evidence. Best available evidence cranberry can effectively prevent UTIs in the SGLT2 inhibitor population. Experience. Clinical experience currently, cranberry is not routinely used. Expectation. Patient values/expectations effective. Easy to take. No side effects, no impact on blood sugar. Environment, clinical context nutritional supplements can be purchased independently. Answering the patient's question, are there other methods, besides enhancing perineal hygiene, to prevent UTIs in diabetic patients caused by SGLT2 inhibitor use? It can be suggested that the patient purchase cranberry supplements. Being bedridden and having a right forearm fracture do not affect intake. It has a certain preventive effect, does not significantly impact blood sugar, and currently shows no side effects. However, attention should be paid to the supplement's ingredients and dosage. 6. Audit. 6. Audit. 1. Is my question clinically important? Yes. 2. Is my PICO correctly structured? Yes. 3. Did I utilize all available resources to gather evidence regarding my PICO? Not really. 4. Did I use the correct appraisal tool? Yes. 5. Do I think this EBM presentation is beneficial for my future clinical practice? Yes. Thanks for your attention.